Hello and welcome. My name is Bob Fury. I'm a pharmacist, and today I would like to talk to you about another group of medication that we see prescribed for the motor symptoms in Parkinson's disease. And this group is called the dopamine agonists. And we have a total of four different medications. The first is pramipexole, also known as Mirapex, the brand name. Ropinirole, or Requip, is the brand name. Rotigotine, which is Nupro, that's a patch, a transdermal patch. It's not an oral tablet. And the fourth is a product called apomorphine. Now, this category is often thought of as the second most effective for the treatment of the tremors, stiffness, and slowness that we see with Parkinson's. And by second, I mean it's second only to levodopa or carbidopa, which of course is still the gold standard of treatment and the most effective as far as the motor symptoms are concerned. Now, the best way to describe how these drugs work is to think of them as kind of a synthetic form of dopamine. So, what happens is these drugs look and act like dopamine, and they kind of trick our receptors into thinking that they're actually receiving dopamine, when in fact they're really not. It's just something that looks and acts like a dopamine product. So although this group is slightly less effective than levodopa or carbidopa combinations, it can be used alone in what we call monotherapy. And this is usually seen in younger patients that are diagnosed very early, perhaps in their 40s or 50s. Um, this particular group of patients have an advantage in that if we can use a dopamine agonist that early on, we may be able to prolong the use of levodopa uh, for as much as many years, actually, before we have to convert them over to levodopa. Understand, of course, that at some point, most patients will eventually need levodopa added to their regimen. But if we're able to forestall that for a number of years and not have the added complications, the motor fluctuations and dyskinesias that are often seen with long-term levodopa therapy, uh, that in and of itself could be advantageous. Now, as I mentioned, there's several different formulations, so let's start right in. The first is pramipexole or Mirapex. Now, this product has been around a number of years. It was approved by the FDA in 1997, and it has two indications. The first, of course, is for Parkinson's disease, and the second is for RLS, which is restless leg syndrome. This could be an advantage because there are many patients with Parkinson's that, in addition to that, also develop restless leg syndrome. So by using this one tablet, we may be able to address both issues for them. When you first start Mirapex or pramipexole, the dose needs to be titrated. So what will happen is your neurologist will put you on what we call a subtherapeutic dose. In other words, a dose that's very, very low and that we don't even expect to see any kind of results at all. And that's really mostly just to establish a baseline to make sure you're not going to have any kind of reactions or nausea or vomiting to the medication at all. Then, approximately every 5 to 7 days, the doctor will increase the dose until you are at a symptomatic relief. At that point, you might be able to convert over to the extended release because the immediate release tablets are dosed 3 times a day. So once we establish what your overall total dose may be, the doctor may be able to switch that over to the extended release tablet, and then you would only have to take it once a day, which would be very convenient. The drug is very well tolerated. It can be taken with or without food. Most patients don't complain of any nausea or vomiting, although if you did, taking it with a small meal, some toast or crackers, would probably very easily alleviate that. The immediate release tablets, they can be broken if necessary, but not the extended release. The extended release tablet cannot be crushed, chewed, or broken in any way, shape, or form. So let's talk about some of the side effects. First and foremost is, as I mentioned, nausea and vomiting. That's pretty common. And again, most patients do very well with this, but for those few that have a problem, just take it along with a small meal, and that should very easily resolve that issue. The second is another condition called orthostatic hypotension. This is the result of when you go from a sitting to a standing position too rapidly and your blood pressure drops. When the blood pressure drops, you can become lightheaded or dizzy. And of course, that's not what we want to see. That could lead to a fall. And that's the last thing we want to do is to end up on the ground. So your doctor is well aware of this as a side effect. And matter of fact, they'll be monitoring your blood pressure very regularly. And be sure that they're taking it in both a sitting and a standing position and measuring that difference because those are parameters that they'll use in order to diagnose whether or not you're having orthostatic hypertension. The next side effect that needs to be addressed is kind of unique in that it's called a sleep attack. Now, this is not your ordinary fatigue or drowsiness that you get. There are many medications that make you tired or sleepy, and this is not like that. This is a sleep attack is something that occurs very rapidly. There's usually no warning. I've read articles and I've spoken to patients that literally in the middle of eating or in a conversation, they just fall asleep. They have no forethought that it was going to happen. If you speak to them after the event, they'll say that you ask them, well, did you feel tired? Or no, I felt nothing. 1 minute I was talking, and the next minute I was sound asleep. Um, that is a sleep attack. And again, your neurologists are very well schooled on the side effect, and they can resolve that relatively easily if need be. The other note I want to make with this is that unlike some drugs that have side effects that are transitory. In other words, the longer you stay on the medication, those side effects tend to either lessen or disappear entirely. That does not happen with sleep attacks. I've read stories of patients that have been on it for as long as an entire year before they had a very first sleep attack. So it doesn't appear that this gets better with time. It's always out there as a potential side effect. So you need to be very careful with this. And obviously, this could be a problem, if you were working or even worse, if you were driving. This could be a real problem. So stay on top of that as a side effect. If you're seeing it happen, or if a caregiver recognizes it, it needs to be brought to the doctor's attention right away. Leg swelling does occur in some patients, particularly around the ankles. Dyskinesias, which we see sometimes, those are those movements that you see. Those are um, uh, unresponsive to some of the other medications. They come on unexpectedly. And finally, the last one that we need to talk about is something called impulse control disorder. Now, this is where patients experience very intense urges to gamble, to binge eat, to wild spending, to bouts of hypersexuality, to the point that it becomes compulsive. This needs to be addressed immediately because this could be devastating if left untreated, especially if they were in a wild spending mode, for instance. Um, Now, it doesn't happen to every patient. As a matter of fact, all these side effects that I mentioned, please understand that not everyone gets these. They're isolated instances, but I mention them because if they do occur, these are the ones that need to be reported as soon as possible to your neurologist because they can make adjustments, whether it's changing the dose or changing the medication or even discontinuing it altogether. And usually that resolves all of these issues. But impulse control disorder, it's extremely important that the patient is well versed on that. But I think it's even more important that the caregiver is well versed in that because what happens sometimes is that the patient may not even recognize that the impulses and the behavior that he's doing is abnormal. To them, they think it's perfectly fine. They don't see a problem with that. So input from the caregiver is extremely important. And another reason why I always advocate at every doctor's appointment, both parties should go, the caregiver and the patient, because you need input from both. That's the impulse control disorders, and that's a side effect. Believe it or not, that's almost with all Parkinson's medications. it's a potential side effect, but it is with this group of medications, the dopamine agonists, that we think of it the most. Um, so again, be on the lookout for this. If in fact it does happen, please mention it to your neurologist. The next one up is Recrip, which is ropinirole. This came out at the exact same time as pramipexole in 1997. Also duly indicated for both Parkinson's and restless leg syndrome. It has the exact same side effects, so we're not going to go over that again. So that just be careful. Same side effects as the other one. It again is very well tolerated, just like pramipexole was. It can be taken with or without food. Again, if you find that you do need to have some nausea with it, just take it with food and you'll be fine. It pretty easily resolves itself. Um, the next one is the patch that I mentioned. This is called rotigotine. And this is a little bit different dosage form. This is not an oral dosage form. It is a transdermal patch that you apply. It's been on the market a number of years, um, and it's applied once a day, which is a nice feature. We're not multi-dosing all throughout the day. So just four brief things about the patch itself. The side effects are going to be identical as they were with the other two medications, so we don't need to rehash that again. But let me talk about the patch itself. The patch, once you apply it, should not be exposed to excessive heat. And by that I mean if using a heating pad in or around the area where the patch is, um, or if you use an electric blanket or go in a hot tub, what happens is that excessive heat has the potential to increase the release of the medication from the patch, and obviously you'd be getting a higher dose than recommended. So that could be problematic. So don't use it anywhere near excessive heat. The other precaution with this is if you have to go for an MRI, do not wear the patch. My guess is, although the manufacturer doesn't state this, but there's probably some kind of metal. Maybe it's a strip of aluminum foil or a piece of metal around the perimeter of it, something like that. I guess it's kind of like putting metal inside of a microwave. So you could get a pretty serious burn from it if you wore it during an MRI. And if you're not really sure and you are going for some imaging procedures, reach out to either your neurologist or to the imaging facility and let them know that you are wearing a Neupro patch and if it's appropriate to wear. Bearing in mind that if you are going for an MRI and you have to remove the patch, even more important to reach out to your neurologist because obviously this is going to be downtime. You're not going to have medication being released. So perhaps you can come up with maybe taking something orally so that your blood levels don't drop of the medication. And then, of course, you'd be going into an off time situation because you didn't have the medication in you. The other thing I want to mention is the placement of the patch. Now, when you purchase it, inside the box, there'll be a patient package insert and a diagram of all the spots on the body that you can apply the patch. My suggestion is when you apply the patch, for instance, if I was going to put it on my left shoulder, hold your hand over the patch for about 30 seconds to a minute. And by doing that, the heat from your hand will help to activate the adhesive on the patch. Because the patch can, once you apply it, you can go about your day. I mean, they say you can bathe with it, you can swim with it. Um, so if it does come loose, I can tell you sometimes around the edges, the four corners of it, if they become loose, you can just put a piece of tape over that. I've seen a patient one time come in to the pharmacy and they had a Band-Aid just over the corner of it just to hold it in place because it became loose. If the patch should fall off for any reason, they suggest you apply a new patch right away up until the time when you're regularly scheduled to change the patch and rip off that new patch and start fresh. Don't try to keep a replacement patch on there all the way through until the next day. Change the patch at your normally scheduled dose. And finally, rotating it. The patch is designed to be placed very firmly, so the adhesive is pretty strong. So for instance, if I put it on my left shoulder today, I have to rotate that to the other sides every single day, and I can't come back to this location for 14 days. So I can put it any place else that they recommend, but not back on my left shoulder for a total period of 2 weeks. And that's really just so that you don't irritate the skin from the adhesive. You keep applying it in the same location. So that's something to be mindful of, because you can otherwise you'll have to put on some cortisone cream, or it could get even worse from the reaction to the adhesive. The last and final group is a product called apomorphine. Um, this has been around many, many, many years. I don't even know when it came on the market. It goes back that far. But right now we have two brand name products that are available. One is called Apokin, and the other one is called Kinmobi. Now, before we move forward on this, let me assure you that even though the name is apomorphine, it is not morphine. It is not an opiate. It does not bind to opiate receptors. It is not an analgesic. I don't know why they came up with that name, but they just did. So please don't let the name mislead you or prevent you from using it, especially if your symptoms warrant it, because this drug is extremely potent and it's very effective for advanced Parkinson patients who are experiencing prolonged and frequent off time. This drug is often referred to as a rescue drug. It's not something that you take every single day like you would your levodopa, for instance. This is only used on an as-needed basis, and it is very effective. And it's had a rich history. Years ago, if you were experiencing a prolonged off time, let's say, the only way that you could actually get apomorphine, because it's only available in an injectable form, you would have to either get to a hospital or an emergency room, or maybe get to the neurologist office, and they would have to inject you with the apomorphine, because there's no oral form of it. But that has changed. In 2004, the FDA finally approved a sublingual injection that can be done at home. This product is called Apokin, and it's a pretty cool in-home kit. It has a pen that looks like very very similar to a diabetic's pen needle, for instance. Um, Comes in a plastic travel kit. You've got the pen in there. You have the cartridges filled with the apomorphine. You've got room for a couple of needles. And when you take the pen out, you'll see on one end of it, you'll just dial in the dose that you're taking. On the opposite end, you just screw on a very fine tip 29 gauge needle, which is super fine, very short needle, almost exactly the same gauge and length that the diabetics use. And the cartridge is inserted in there. It's a multi-dose cartridge, so you can take several doses out of it. And it can be used subcutaneously, right underneath the skin. But more importantly, it can be done by the patient or even the caregiver with very simple instructions on how to do it. Anybody can administer this. It's not complicated at all. And it works very rapidly, 5-10 minutes. It's in the bloodstream, and those symptoms disappear right away. I said this drug is excellent for that. Just as a sidebar, I want to mention that some patients may have tried in the past to obtain this product, Apokin, and their insurance wouldn't pay for it. Some insurances, because it's only available in, or was only available in, a brand name. And some insurances either don't pay for the brand straight up, or they have a copayment that's ridiculously high because it's a brand name drug. However, that's changed. Just this past February of 2022, the FDA cleared way for a generic to be released. So it is now available. Apokin subcutaneous pen needle kit is available as a generic form. Therefore, the insurance companies should pay for it. So if you had issues with obtaining it in the past, you might now be a candidate for it, since it's become available generically. Also, now that's changed too. Back in 2020, the FDA cleared the way for a product called Kinmobi. Now, this is interesting because if any of you remember the old Listerine films that they came out with, that you could just peel off this little film, came in a little cartridge case, and you just placed it on your tongue and you dissolved it, and the Listerine would be dispersed. The exact same kind of technology is being used here with Kinmobi. It's a film, a subcutaneous film that you take, you place it under the tongue, and it dissolves relatively quick, almost instantly, and it gets the medication into your bloodstream very quickly. The advantage here, obviously, there's no needle stick. That's number one. But number two is that you can use it up to 5 times a day as long as the doses were spaced out by approximately 2 hours. So for those patients that were, rather than having needle sticks 5 times a day, you could just use this sublingually and get the same effect. Now, also, the same drug, as we speak, literally, this is the month of September, the FDA has, I should say, the manufacturer of Apokin has now filed an NDA, a new drug application with the FDA for a Apokin infusion pump. Now, the FDA has acknowledged receipt of all the paperwork and all the clinical studies, and they have sent a letter back to the manufacturer committing to October, which is just a couple of weeks from today, to begin their review of all of their material. And pending the results of that review, as long as the FDA clears it, and kind of the scuttlebutt is that they're going to, it looks that way, the manufacturer is pretty much geared up and ready for production first quarter of 2023. So, when I first heard this, I said, you know what, this seems like it's going in the wrong direction. I mean, we just finally went from it having to go to my doctor to get a shot to now getting a subcutaneous kit called Apokin to now getting it on an oral film where I don't have to stick myself. And now we're going to get an infusion pump where I've got to deal with the needle again. But when you think about it, it really is a great idea, almost identical to an insulin pump that a diabetic would use, where you can get a continuous plateau, a smooth level of apomorphine without this sawtooth pattern all day long. So for a certain population of patients, that's a great thing, especially if they were having frequent off times all throughout the daytime hours. Um, you'd now be able to get this even plateau dispersed throughout the day. So from that perspective, it seems like it's a good thing. Um, and also another advantage to that is some patients have very complex dosage regimens because of all of these fluctuations. They're taking tablets and pills as often as every 2 or 3 hours, where we may be able to eliminate some of that because now we've got this steady state level of apomorphine circulating. So that in itself could be a great thing. Additionally, some patients have um, absorption problems. Their digestive tract, everything in Parkinson's is slow, especially digestive problems. Things don't move fast. They have delayed gastric emptying. So taking pills orally is a huge problem. They can sit around waiting for these things to kick in. So now by having this continuous infusion, they don't have to deal with that. It bypasses the GI tract automatically, so they don't have to deal with GI absorption issues. So overall, I think anyway, this would be a wonderful new addition to the arsenal that your neurologist would have to treat some of these patients. It's not going to be for everyone, but it would offer an absolute life changer for some patients that are dealing with this. And if you want to see what this looks like, it's not available, as I said, yet, but it is available in other countries. For instance, the United Kingdom, the UK has one out. It's called ApoGo, APO-GO. And if you want to see what it looks like, you can Google ApoGo and you'll see it's a very small pump, fits in the palm of your hand. Attached to that pump is a very small reservoir. It looks like a plastic syringe where the apomorphine would go. And then a very fine tube connected to a very thin needle that would go in the abdomen that the patient themselves does. And the pump would clip on a belt or on the waistband. And there's a couple of dials on there, apparently for your dosage. And that's it. That's all there is. And just like an insulin pump, it would be going all day long. So take a look at that if you're curious about it, and stand by for early 2023. You may see that product on the market very soon. So with that, I think we've covered all four of them. I hope you've learned something new about your dopamine agonists, and I'll see you on the next one.